The broadcast is now starting. All attendees are in listen-only mode.
Welcome to today's session entitled Care Partners, Bridging Families, Clinics, and Communities to Advance Late Life Depression. Before we get started, I'd like to go over some items so that you know how to participate in today's event. When you joined today's webinar, you selected to join either by the phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing the audio pane in your control panel. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send your questions in at any time. We will collect them, address them during the live Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar. John?
Thank you, Lucy. I am delighted that so many of you have joined us today. And we want to send a special welcome to our colleagues at Grantmakers in Health who are joining us on this special webinar. According to the National Alliance on Mental Illness, depression affects more than 6.5 million of the 35 million Americans 65 and older. In 2014, Archstone Foundation launched its Depression in Late Life initiative. And as part of that process, awarded a 4-year grant to the University of Washington, the University of California, Davis, and to support the Care Partners, Bridging Families, Clinics, and Communities to Advance Late Life Depression Care project. We are so pleased to be joined by Laura Rath, the Senior Program Officer at Archstone Foundation, and Dr. Ladson Hinton, geriatric physiatrist, clinical services researcher and social scientist at UC Davis, and the co-director of the Care Partners Project. We welcome you both. As we mentioned before, we would like for you to send your questions at any time for our presenters, and we will have that presentation and answer of the questions at the end of our session. Please go to the question box that is on the right side of your screen. Open the question panel and type in your questions at any time. Laura, let's start with you to give us an overview of the important work that Archstone Foundation and others are supporting in this area.
Thank you, John, and thank you to my colleagues at Grantmakers in Aging and Grantmakers in Health for making this webinar possible, and thanks to all of you who have joined us for today's webinar. We'll begin with an overview of the topics on the next slide for today's webinar. So to begin with, we'll look at some of the background on the issue of depression in late life and why it's important to the Archstone Foundation. Then Dr. Hinton will be walking us through the need to improve late life depression care, discussing collaborative care in primary care and in the community. Then he'll discuss some of the innovative approaches involving community partners, the successes and challenges, as well as lessons we're learning through this work. Then we'll talk about some of our hopeful next steps and also have time for some questions and answers. On the next slide, we'll begin to move through our outline. And again, I'll be starting with some of the background on how we at Archstone Foundation came to this important work. So on the next slide, I'll begin with some of the background about Archstone Foundation. Located in Long Beach, California, the Archstone Foundation is a private grant-making organization whose mission is to contribute toward the preparation of society in meeting the needs of an aging population. The foundation was formed in 1985 through the conversion of a nonprofit health maintenance organization to a for-profit corporation. And now, after more than 3 decades of operation and more than 1,000 grants awarded, the foundation's grant-making has now surpassed the initial endowment with over $100 million in grants awarded. Our current funding priority areas include aging in community, mental health, and family caregiving. Previous Archstone projects to address mental illness have included the Senior Mental Health and Substance Abuse Project, clinical mental health outreach to older adults, caregiver support programs, and the Early Stage Dementia Project. Additional early work back in 2011, the Foundation supported the replication of evidence-based programs that seek to identify and treat depression in older adults in Southern California. At that time, projects supported by the Foundation included the Improving Mood, Promoting Access to Collaborative Treatment, or IMPACT model, the Program to Encourage Active and Rewarding Lives for Seniors, or PEARLS project, and the Healthy Ideas program, identifying depression and empowering activities for seniors, as well as programs to address depression among caregivers. Next, we'll look a little bit more at the Depression in Late Life initiative. Given the stigma often associated with depression, combined with the high numbers of older adults that suffer from depression, the Archstone Foundation decided to seek to address the issue through sustained multi-year funding. The goal of the Depression in Late Life initiative is to improve the quality of life for older adults through the expansion of evidence-based models of care that identify and treat depression. In partnership with the University of Washington and the University of California, Davis, Archstone is supporting the Care Partners bridging families, clinics, and communities to advance late life depression care. Specifically, through this initiative, we're supporting innovative partnerships that can improve depression care. The partnerships include involving family and community-based organizations in an older adult's treatment of care, and support to the University of Washington and University of California, Davis has helped the Foundation in developing the initial request for proposals, assistance in the review and selection of sites, offering clinical and technical support to the applicants and awarded sites, and in fostering a learning community among the awardees. Next, we'll turn to our funding timeline, and this shows a brief history of the work that we've done since 2013. We began in 2013 and 2014 by reviewing the issue and working with our board of directors to select a strategy. That was when we initially engaged with Dr. Hinton at University of California, Davis, and the terrific researchers at University of Washington as well. Based on their feedback and the input from our board, in 2014, we released a request for proposals and worked with our technical assistance providers to select sites and begin implementation of phase 1. Then from 2017 until the present, we've engaged in the second phase of this work, where the first cohort had the opportunity to continue the projects and sites that they were implementing, and where we also had the opportunity to add a second cohort of sites across the state. Next, we'll turn to our initiative goals for the Care Partners project. We're looking to innovate on collaborative care through partnerships by adding community-based organizations or family care partners into enhanced collaborative care or partnered collaborative care. Again, in phase 1, we focused primarily on the IMPACT model, where sites had the opportunity to link their clinical practice with either a community-based organization or in combination with including family members in care as well. Sites implemented collaborative care in some cases while also implementing this partnership work. And we'll revisit this in some of our lessons learned as well. Moving into phase 2, as I mentioned previously, phase 1 cohort had the opportunity to continue, as well as in phase 2, we allowed sites to select from either the IMPACT or PEARLS model, and then to continue to collaborate with either a CBO or family member. Here on your screen, you see the phase 1 sites that were included in 2014, and as you can see, we had sites selected from across the state here in California. Next is a listing of our phase 2 sites, and you can see again, that some of the phase 1 cohort sites decided to continue in implementing their model, and then as well as we had the opportunity for some additional sites to be added as part of what we're calling cohort 2. And again, you can see these are selected from across the state of California. And now it's my pleasure to hand over the presentation to Dr. Ladson Hinton, who will tell us more about the details and implementation of our Care Partners model. Dr. Hinton?
Yeah, thank you, Laura, and hello, everyone. Next slide, please. So it's my pleasure to guide you through the next part of this presentation. And the first thing I'd like to do is just to amplify a little bit on what some of the comments that Laura made about late life depression. And next slide. So what is late life depression? You know, I think it's important to emphasize that it's a lot more than just having, you know, a bad day, a bad week, or even a bad month. It's characterized by a pervasive sense of depressed mood, of sadness, or a real feeling that one has lost interest or the ability to derive pleasure from activities that are normally pleasurable. It involves a number of additional symptoms like lack of energy, fatigue, poor sleep, loss of appetite, feeling physically slowed down or agitated, having difficulties concentrating. And in older adults, late life depression also can often involve a lot of physical symptoms like aches and pains, irritability, and it's also associated with thoughts of guilt and even thoughts of wanting to end one's life. It's a miserable state that really impairs quality of life. It can go on for months or even years. Next slide. So one of the very most serious consequences of late life depression is suicide. And we have in our country very high rates of suicide among older adults, and that's shown on this slide, basically looking at sort of rates of suicide across different age groups. And what you see at the far right end of this graph is that the rates of suicide are highest among older adults, you know, aged 70, 75, 80 and up, and that these rates are actually most elevated among older men, particularly older white, non-Hispanic men, but to some extent among African American men as well. Not represented on this graph are older Asian American men and older Latinos. They also, men in those groups also have higher rates of suicide, probably intermediate between those of African American men and white non-Hispanic men. Older women have much lower rates of completed suicide. So this is just one of the many adverse consequences of late life depression. There are others as well, that depression really impairs quality of life. It can drive up healthcare costs. It's associated with worse functioning, worse outcomes from some medical conditions. And it can also be a very stressful and difficult thing for family members of people who have depression. Next slide. So how good is our current depression care? If you look at the data on older adults who have depression, only about 2 in 10 or 20% see a psychiatrist or a psychologist. And the majority of older adults who receive treatment for depression do so in primary care. There was really an interesting study that was done back in 2008 by Dr. Ming-Tai Seal, in which basically she and her group actually recorded interactions between depressed older adults and their primary care physicians in primary care, and then analyzed those recordings. And basically what she found is that the amount of time that was devoted to sort of addressing mental health aspects of the patient's condition averaged only about 2 minutes. And so what we see is that even though a lot of older adults receive treatment in primary care, you know, sometimes the amount of time that's really devoted to addressing those issues is fairly minimal. 4 to 5 million older adults, many of whom have depression, receive an antidepressant, but only about 20% of those older adults with depression actually improve. And very few get effective psychotherapy. So we do have access to antidepressants in primary care. What's much less common is access to effective psychotherapy, which really is quite effective for late life depression. And I'll be talking about some of the different types of evidence-based psychotherapy just a little bit later on. Next slide. So now I'd like to move on to talk about a model of care, collaborative care, which has really been shown to strengthen depression care for older adults in primary care settings and to really improve outcomes. Next slide. So what is collaborative care? Basically, collaborative care is a model of depression care that's embedded in the primary care setting. It's a team-based approach. And the key members of the team, in addition to the patient, are the patient's medical provider. Then we have a care manager and also a psychiatric consultant. And so this team works together with the patient to address their depression. The role of the medical provider is that, you know, in a lot of healthcare settings now, there's depression screening. And so the medical provider and sometimes their staff, such as nurses and others, identify older adults who are depressed. Then that older adult who's depressed is handed off or connected with a care manager who's usually a social worker, or it could be a nurse, also embedded in primary care. And that care manager has a really critical role in the collaborative care model. Initially, they're involved in doing further assessment of the patient's depression, and then they work with the patient to deliver evidence-based treatment for depression, including different types of psychotherapy, such as problem-solving therapy, behavioral activation. They also use motivational interviewing. The patient also may have access to or may be prescribed medications for depression. The care manager communicates with the primary care provider, who then will prescribe the antidepressant for the patient. And then a very important part of this team is the psychiatric consultant. The psychiatric consultant typically will, with some exceptions, will not see the patient directly, but will consult with the care manager and also the primary care provider to make recommendations about when to adjust medications, when to prescribe a medication. And sometimes with patients who are more complex diagnostically, are much more treatment resistant, the psychiatric consultant may actually see the patient for a few sessions to help with this team-based approach to care. So some of the key elements of the collaborative care model are, one is the use of objective outcome measures like the PHQ-9, not only to screen for depression, but to monitor the response to treatment over time. A key to this model is a population registry. So all of the patients who have depression become part of this registry. And this registry is used by the care manager together with the psychiatric consultant, sometimes also together with the primary care provider, to review all the patients who are being treated for depression and to really identify those who may need a change in their depression treatment because they're not improving sufficiently. So this registry is really critical and is a real, I think, a significant improvement over what routinely happens in primary care settings. I mentioned some of the treatment protocols for evidence-based therapy. Those include problem-solving therapy, behavioral activation, motivational interviewing. And then we see over on the very far right-hand side, the psychiatric consultant, who again plays a really important role on a weekly basis in consulting with the team and reviewing all of the patients who are in the registry. Next slide. So we have some really good evidence about how the collaborative care model improves depression care and outcomes. So this is from a study that Dr. Unitzer, who really is the developer, is really the lead investigator who developed this evidence for collaborative care. In studies that were conducted back in the early 2000s, this is from JAMA, and in a randomized controlled trial, which is really the best form of evidence for showing that treatments are effective, that Dr. Unitzer and his collaborators demonstrated that in a sample of more than 1,700 older adults, that the collaborative care model essentially doubles the effectiveness of care for depression in primary care settings. And here you see across a number of different organizations, the orange bars represent the percent improvement in depression and collaborative care compared with the blue bars, which represent just usual care. So these two conditions were compared in this randomized controlled trial. Next slide. So, I've talked about collaborative care. There's actually kind of what I would call sort of a version of collaborative care that's embedded in the community. It's called PEARLS, which stands for Program to Encourage Active, Rewarding Lives for Seniors. In the PEARLS model, the care manager actually works with patients in the home to deliver these brief behavioral techniques that I talked about earlier. And again, the PEARLS model is very similar to collaborative care in a number of different respects. And there's also good evidence that it's effective for treating late life depression. Next slide. So now I'd like to move on to the Care Partners Initiative and how it's innovating the collaborative care model, I think, in some really important ways. Next slide. So Care Partners, the Care Partners Initiative basically takes the idea that collaborative care for depression can be strengthened if primary care works more closely with partners in the community. And by partners in the community, we mean either working more closely with community-based organizations or with the depressed older adult's family or friends. So it's finding ways that this collaborative care model can be strengthened through these partnerships. So there are a number of ways in which both CBOs and family and friends can strengthen collaborative care. They can help older adults get better access to care. So we not infrequently see, for example, when I'm working in my clinical practice at the VA here with older adults, that an older adult may be brought in for care or really encouraged to come in for depression care by a family member or friend. CBOs and family and friends can also really help to support the older adult in their depression treatment at the beginning of the treatment itself. So to help engage them in treatment, encourage them to stick with it. And so I think that's another important area for strengthening of collaborative care. Sometimes patients actually prefer to have, people they know at community-based agencies or family and friends be part of their depression care experience. And so I think it can strengthen patient experience in that way. It can also improve the quality of care that through partnerships with CBOs, for example, that staff at the CBO may be able to encourage the patient to adhere to medications or to the behavioral techniques that they're engaged in to treat their depression. So again, that CBOs and family can strengthen different aspects of care. In behavioral activation, for example, which is one of the behavioral techniques, what we found is that family members or friends can really help older adults to follow through on some of their goals in behavioral activation by engaging in sort of pleasurable activities on a daily or even weekly basis. And sometimes family and friends can actually participate in those activities together with the person who's depressed to enhance, again, their adherence to the treatment. So we know that collaborative care is effective, but I think engaging CBOs or family and friends to strengthen collaborative care is really an innovative approach. Next slide. So this is the traditional, model of depression care that I talked about much earlier, which involves, a depressed older adult being seen in primary care, their primary care provider diagnoses depression, maybe spends that 2 minutes talking with them about some of their needs and prescribes an antidepressant. So not really particularly effective. Next slide. So we've reviewed the collaborative care model. So collaborative care really changes the landscape of treatment in primary care in a really dramatic and effective way by developing this team that involves not just the PCP, but importantly, the care manager and also a psychiatric consultant. So the three of them work together to strengthen the patient's depression care and really monitor it on an ongoing basis and make adjustments in treatment using measures like the PHQ-9 if the patient is not improving. Next slide. So the innovation of care partners is actually to now take that collaborative care model, but engage community-based organization or family and friends as part of the care team. Next slide. So community-based staff at community-based organizations and family and friends have a number of different roles in this enhanced collaborative care model. Family members and also staff at community-based organizations can help with outreach and screening for depression. They can assist in the process of diagnosis. For example, a family member may be able to work with the care manager in primary care and provide additional details about the patient's history that can help with diagnosis. The CBO and family can either participate in depression psychoeducation or reinforce that psychoeducation and about depression with the patient. In really important ways, CBOs, I think, can address unmet needs or social determinants of health that are not as easily addressed in primary care settings. And so these often contribute to depression in older adults. And by coordinating across primary care and community-based organizations, I think these needs and important determinants of health and depression can be better addressed and coordinated. CBOs and family, again, can help with medication management, encouraging the patient to adhere to treatment, and also to reinforce brief psychotherapy. Next slide. So now I'm going to move on to just share a little bit in terms of some of our successes, some of the challenges we've identified in implementing this innovative model of enhanced collaborative care. Next. So we here at UC Davis, our role has been to kind of lead the evaluation. And if we could just highlight the next couple of bars here on the slide. So the goals of the evaluation are multiple. The first is to see how this model, enhanced model, was experienced by key stakeholders, including staff at primary care clinics and also community-based organizations. Next. Also to describe how this enhanced collaborative care model was implemented across the different sites. Next. To help to work with the University of Washington to evaluate the outcomes of the interventions, to answer questions such as, did this intervention work? How did patient outcomes improve? For whom? Under what conditions? And also to describe the development and evolution of the overall initiative. Next slide. Next. So we have several different sources of data listed here. As part of the evaluation, we have data from CMTS, which is that registry, which documents patients' PHQ-9s over time in treatment, and also is a way of tracking their engagement with both family and community-based organizations. We have done interviews with semi-structured interviews with staff. Next. Also focus groups with staff. Next. And also we have generated through this project a lot of documents that have really been valuable for the evaluation process. Last, but certainly not least, another innovative aspect of this project is we actually have tracked costs and have a nice paper that Dr. Hooft has published together with the team that captures the costs of implementing this enhanced collaborative care model. Next. So this is actually the registry, kind of what it looks like. These are fictitious names, and I won't say a lot about this, but again, this is really a cornerstone of this collaborative care model, is really tracking, all of the different patients in this registry. And what typically happens in depression care is that a patient comes in, they're treated, they're given a follow-up appointment, and then the next patient is seen, and we don't really systematically track patients over time to see who we need to really focus on and where changes in treatment need to be made. And this registry is really tremendously important in helping to do that. Next. So these are some of the lessons learned from phase 1 of the Care Partners Initiative. There were a number of challenges. And one of the challenges I think that a number of the sites faced is they were trying to both implement collaborative care, but also to implement this enhancement, which is the collaboration with a community-based organization, more or less at the same time. And that was pretty challenging for some of the sites. So our lesson there for phase 2 was that it was really important to do this in a kind of phased process, so that for phase 2, basically we've selected sites that have already implemented collaborative care effectively, and then they're only working on this innovation, which is to collaborate with care partners. We also found that identification of potential depressed patients at CBOs is sometimes challenging for a number of reasons, and one of which is that often CBOs are working with multiple different healthcare clinics, and so it did create some challenges. And I think the upshot here is that sites need to be very flexible and have multiple avenues and strategies for identifying patients for this depression care model. Sometimes patient engagement with family and CBO is complex. And again, I think it's important for organizations to be very adaptable and creative in how they engage patients with either the CBO or with family members and engage them in care. What we call diffusion of responsibility can be a challenge. And that's because when you begin to move into these innovative sort of, partnered models of collaborative care, you have more people who are involved. And it's really important to have clear accountability and responsibility outlined for the partnership. And what's absolutely critical, we found, is to really have kind of a champion at each of the sites who will really take ownership and accountability for getting the patients good treatment. And finally, collaboration and task sharing across organizations can sometimes be quite challenging. And we've actually developed a number of different sort of tips for sites that are interested, or organizations that are interested in doing this kind of work. Next. So these are the adaptations from phase 2 based on our lessons from phase 1. Again, sort of that the sites have to have impact or pearls actually implemented at the time that they entered, that they were given these grants to innovate collaborative care. They needed to have a clear communication infrastructure between partners, and this is really critical, so that if you have a CBO collaborating with primary care, they have to be able to communicate about how the patient is doing in terms of their level of depressive symptoms. So this communication infrastructure is really critical. Again, having a champion at each organization or site is really important. And also to have ways of dealing with turnover of staff, with which we have found is a real challenge for a number of these organizations, that staff are turning over, and you have to have a way of sort of socializing, educating new staff about the model. And again, to develop that flexibility about when to involve and how to engage family or other care partners in care. Next. So these are what we've done. One of the products, I'm not going to talk about this extensively here because of sort of the time limit, but we did, out of phase 1, we developed 6 tip sheets that basically map onto our lessons learned from phase 1 and basically describe tips that actually were developed from the different sites themselves about how to negotiate or deal with some of the challenges in doing this partnered collaborative care. And so these tip sheets address, one, the development of partnerships, identifying patients, screening and identifying patients, engaging providers, leadership, staff at partnering organizations, engaging patients, partnering with family to strengthen depression care, and task sharing, those different aspects of collaborative care across community-based organizations and primary care. Next. This is one of the tip sheets we developed, and so this is the tip sheet on development of partnerships. And again, this looks at developing partnerships across primary care and CBOs, and how that can be done at both the organizational level as well as the interpersonal level. Next. So one of the sites from phase 1 was Sonoma, Petaluma, and they actually found, I think, some really effective ways to deal with some of these challenges. So this was a partnership between Petaluma Health Center and Sonoma County Aging Services. And so one of the challenges that they had was how to communicate information about patients. And so at Petaluma Health Center, they worked to actually get staff at Sonoma County Aging to have access to the electronic health record so that they could see how the patient was doing in terms of their depression care. And so that became a really important way to communicate about patient care. The other thing that they did that was really, one of the other things I think that was really important, is that Petaluma Health Center actually created space for the care manager from Sonoma County Aging Services to actually be in the health center, and they held weekly team meetings where they would go through, using the registry type approach, go through all the patients who were engaged in the care model and be able to have an interdisciplinary team conference to share perspectives and thoughts and strategies about how to get the person with depression better. Next. There's a really nice video. We don't have time to show it today, but I think the link is going to be sent out to everybody who's participating in the webinar. Really encourage you to see this. This is about the Petaluma, Sonoma kind of site, and really a nice illustration. Next. So I am going to turn this back over to Laura Rath for the remainder of the webinar before the Q&A.
Thanks, Ladson. And although we've had the great opportunity certainly to work together over several years, I always pick up on new information. And in particular, I thought the list of different ways that the care partners can interact and assist the team was really interesting for me to hear about. So yes, next we're going to talk about our next steps with this work here at Archstone Foundation. So first, we're continuing to support the sites that you saw at the top of the hour. Phase 2, we have our cohort 1 sites who are continuing to scale up and expand their programs. And in our second cohort of phase 2, they're about a year into developing their new partnership programs. And those sites really now are getting to the point where they're enrolling patients, testing their models, and working through those partnerships between the clinics and their selected community-based organizations or with those family partners. We're also going to continue to develop dissemination materials to help others who are interested in this type of work. Specifically, we want to learn more about how to replicate successful programs, and that's part of the evaluation and research that Dr. Hinton reviewed with us today. And also, we're interested in implementing strategies for improving partnered collaborative care. Another piece of this is that although the sites will continue for an additional 2 years in the projects that they've outlined, we're also going to look to share these lessons that we're learning when we come to the end of this second phase through a more extended learning collaborative here in the state of California. And again, we'll be looking to work with our research and evaluation and technical assistance team at University of Washington and University of California, Davis to identify other clinics and community-based organizations who might be interested in joining that type of learning collaborative. So certainly as that comes closer, we'll share more information with this audience as well if they know of sites that would be interested in participating. As well as we'd like, if the GIA and GIH audience is interested, we'd love to share more information in the next year or so about the results and more of the lessons that we're learning in this second phase. Next slide, please. We also wanted to give some suggestions for next steps or ideas for funders who are interested in this work and some things to consider. The first would be to provide training for your board members or trustees or staff about the importance of addressing and treating depression in older adult populations. And I think even the first half of this webinar provided such a great overview of the importance of addressing depression because of those links to mortality and because we have identified programs that can really help older adults in addressing their depression. So what could you do locally? You could see what clinics and health systems in your area have collaborative care. We want to make sure that mental health is part of the holistic health care that's offered to older adults. And something that foundations could do is provide startup cost support for those local primary clinics to implement either the IMPACT or PEARLS models of collaborative care. So they could provide that funding directly to the clinic sites or through technical assistance to work and engage with the AIMS Center at University of Washington to provide that support in establishing collaborative care if they don't already have it at their clinic. And then again, as we saw earlier, the results of that randomized clinical trial that happened in the early 2000s, there's already a strong evidence base that this partnered collaborative care works and improves usual care by 50%. So the evidence base is already there to establish and replicate these programs. And then once collaborative care is established, or if you identify clinics in your community where collaborative care is already up and running, we would suggest that the next step would be to look at partnering with community-based organizations or family members because of the value that they can bring in improving that care team. And then another idea would be that you could think about how to apply this partnership model or the principles of collaborative care to other diseases. And one example might be that you could help address dementia by supporting partnerships between clinics and community-based organizations. And if we have some time during the discussion, I think Dr. Hinton would have some more examples from his clinical experience of how this could really work well. And then finally, you could support CBOs to partner and network to approach the clinics to provide services that address the social determinants of health. So it's really, the two approaches where clinics can reach out and think about adding partners, and then also having the community-based organizations that you work with think about framing the services that they can offer to approach clinics to be able to improve care in that way. Next slide, please. Next, we just wanted to briefly highlight some of the wonderful research articles that have already been published on this work. And as we've mentioned, Dr. Teresa Heft is joining us today and would be happy to answer any additional questions about some of the costs of implementing this work, you know, and some of the future directions for improving late-life depression. Next slide, please. Great, and then these are some additional resources that could be of value to you if you're looking for more information about how to implement this work. Next slide, please. Great, and before we move into the discussion and question and answers, I just wanted to take a moment to say thank you for your time, interest, and attention in this topic today. And now I'd like to hand it back to John in the studio.
Thank you so much. And thank you for both of you for the excellent presentation and the fantastic work you're doing. There's actually several questions that relate to costs, so we'll bring in Dr. Heft at this point. So this all sounds wonderful, but the questions are basically, how much does it really cost to get a program like this up and running? And what suggestions would you make to funders about the scale of funding that they might be looking at if they wanted to start a similar effort?
Sure, yeah. Thanks, John. So my background is in health services research and health economics. And so coming into the project, I was really interested in looking at costs. And thankfully, with encouragement from the Archstone Foundation, we did go ahead and do a small project. We looked at, it's a nice question to actually encompass both of the things that we looked at, which is the planning and implementation cost to get things up and running, and then additionally the cost to support care delivery. And so in the planning phase, folks are just getting all of the people hired and trained and managing all of those details and working out their workflows. And then as they start implementing, they're engaging patients in the care. So what we found is that with the partnered collaborative care, that it was more costly, and the site that did do the best and really had strong involvement from both sites in those planning costs. It did add to the costs, and so that was on the higher end, and it was about $60,000 over the course, and that is just kind of the planning and implementation phase. So then factoring in the care for patients that's ongoing once they start implementing, that added an additional, probably for that year, significant about 70-some thousand. So it did actually fall nicely within what the grant period, the grant award of $150,000 was for that site. So I guess we could say that was sufficient for getting collaborative care up and running with this site. And the award for the original grant was 2 years at $150,000 each, if that's a helpful guide.
Thanks, that's very helpful. A follow-up question to that. So the clinical care itself, is that provided through Medicare, private insurance, Medicaid, or is there one of those that's more predominant?
Oh, that's a great question. So there are a lot of things that can be billed for, and it will depend on the sites. We actually worked with a lot of FQHCs, so they'll have a different funding mechanism as well. And it helps me clarify that the cost that we were looking at with the cost of care is just those additional costs that can't be billed. So we really looked at the administrative costs, the running the registry, the tracking the registry, the phone calls to patients to engage them in care and get them back into the clinical setting. So each site has a mix of different payers paying for billable services, and then what we've looked at is the additional costs, which there are now billing codes for collaborative care, which only came about recently during the course of our project here. So sites can get some additional funding for those additional costs now.
And this is Laura. Just to add to that, from the Foundation's perspective, for the Phase 2, second cohort, we offered funding levels for the first 2 years at $150,000 per year, and then in the third year, $75,000. Again, to address the staffing and startup costs and the coordination costs. So if that provides maybe some helpful context as well.
Thanks very much.
This is Ladson. I just wanted to add one other thing, is that in phase one, sites were actually trying to both implement collaborative care and do this partnered collaborative care at the same time. And it will be really interesting to see in phase two what the costs are associated with implementation of this partnered aspect of collaborative care, since all of the sites already have implemented collaborative care at the start of the project.
Great. Thank you very much for that. Laura, this is a question probably more directed towards you. If there were additional aspects of this particular area which were not this specific program that foundations might engage in, are there other suggestions about things in the general area of depression that you or Archstone Foundation might suggest for other, particularly local and regional foundations?
That's a great question. Thanks, John. And again, we're based in Southern California, although this was a statewide project. So we certainly understand, other foundations who are, looking locally. And I think that goes back primarily to identifying those primary healthcare clinics, or FQHCs, in their local area, and maybe to take a look and see if collaborative care is already offered. And thinking about, if they might assist clinics, in making sure that that first step of having collaborative care implemented is happening. And I think, that's where maybe Dr. Hess could tell us a little bit more about, what those initial costs might look like. But I think something else that's really great is that there is that billing code now available for clinics to be able to receive payment for those depression care services. And then once that kind of baseline is established, that's where we can think about some of these additional innovations of adding the additional partners.
This is a question now for Dr. Hinton. In your experience as a psychiatrist, what have you found to be the most useful part of this model as opposed to other models you've been working at?
Well, I think there are probably a couple of different things that are really important about this model. I would say that one is that there are some older adults with depression who really have problems accessing the collaborative care model in primary care settings. So I'm thinking about an older adult who has multiple medical problems, has difficulty getting into the clinic. And what this model, in partnering with a CBO, for example, that's able to go out and do home visits, that they can that older adult who has trouble getting into the clinic can have much better access to some of these behavioral techniques that really enhance depression and really get much fuller and better treatment for their depression. I would say another thing that's quite important is that in primary care, in the traditional kind of primary care depression treatment model, we only see, I think, part of the patient's life and the different things that are kind of triggering their depression. And what we don't see as much is what's happening in the home or what's happening in the community or their social needs, et cetera. So that I think this model really has a wonderful potential to allow depressed older adults to be treated more holistically and in a way that's much better than simply referring a patient from primary care to a community-based organization. Because through this communication across the two organizations, primary care and the CBO, I think that depression care can be much more effectively strengthened. And again, depression can be treated in a more holistic way. I think the last thing that I'll mention is that there are a subset of older adults who really rely a lot on family members for help with their depression. And I think we have seen that through this project, that for a subset of these depressed older adults, it can really be very important and effective to also engage family members.
Well, thanks so much. Unfortunately, we're reaching the end of our time here, and we want to turn to each of our panelists to have their final words about today's discussion. And Dr. Heff, would you like to start? Are you on mute?
Thank you. Yes, thanks. I just wanted to say thank you to the foundation and Ladson and the audience for tuning in. It's just been really a pleasure to be a part of this.
Dr. Heff?
You know, I wanted to just conclude by, you know, emphasizing that there are important reasons for taking this evidence-based model, which is collaborative care, and trying to enhance it in certain ways. That even under the best of circumstances, traditional collaborative care is shown to actually improve outcomes for about 60% up to maybe 2/3 of older adults with depression. But there are a significant number of older adults who need more. And I think this enhanced model has the potential to provide access and improve outcomes for a larger segment of the older adult population. And again, to treat depression in a more holistic way by taking into account some of these social determinants of health and mental health.
Laura?
Thanks, John. Again, I want to thank our excellent audience for joining us and taking time out of your day to learn more about this important topic. I want to say thank you to Drs. Hinton and Heft for sharing their expertise with us. And of course, a thank you to Grantmakers in Aging and Grantmakers in Health for making this platform possible. At Archstone Foundation, we think this is important work and has such critical implications, just as Dr. Hinton said, for improving the health and health care of older adults. So, something that we've certainly learned is that partnering to provide this care is difficult, but so important. And we hope that you will consider how some of these lessons might be integrated into the work that you're doing. And of course, we would invite you to follow up with us. I think my colleagues as well, Dr. Hinton, his team at the university, myself, and all of us at Archstone, if you have additional questions, we'd be more than willing to share any lessons or additional information that might be helpful in your work.
Well, I want to thank Laura Rath from Archstone Foundation and Drs. Ladson Hinton and Teresa Heff from the University of California, Davis, and the Care Partners Program. And we also want to thank Archstone Foundation for the support of this webinar and our colleagues at Grantmakers in Health for not only joining us, but also helping us to put together today's work. We will be making this presentation available to everyone who wishes to view it later, both including the slides and the audio. Watch for a rebroadcast link on our website. And finally, I want to thank all of you for participating in today's webinar. Have a great day.